All right, well, just to start, the title of the presentation, obviously I'm not going to cover all of those aspects. I mean, it's a massive topic. We'd be here for probably 2 days. But what I can talk to today is one of the initiatives that we have operating here in Tasmania. I only started in the role in February, and normally my substantive position is the nurse unit manager of our secure mental health unit, so the Wilfred Lopez Centre. So obviously that unit, we are managing some of the most difficult behaviours for consumers. So I guess I'm used to working in an area that's the pointy end of the spectrum. The Safewards project has come out of research that's been done internationally, and it's also come out of some studies that have been occurring in Victoria. So I'm going to talk about the model and a little bit about what we're doing to implement that here and how we think that's actually going to impact on instances of aggression, instances of conflict and violence in the workplace as it relates to working in an inpatient unit. I think there's applications across various areas where we come into contact with consumers, but we'll talk a little bit about that later on. Okay, so the first thing is, where did Safewards come from? Well, Safewards is really about keeping everybody safe. It is what it is. It's about having a safe ward. It's really quite a simple concept, originated out of the UK. Professor Len Bowers, who's now actually a retired nursing professor, and a number of his colleagues came up with the idea of looking at instances of conflict, containment, violence, aggression, all of those things within inpatient psychiatric settings, and trying to determine what it was that we could do maybe about improving that. So it's research-based, it's gaining a lot of international interest. There's an international community of practice that actually operates out of all things out of Facebook. So, you know, if you are a clinician working with these issues, you can link into that international community, and, you know, you'll find that the issues are the same wherever you are in the world. One really good thing about it that we like in Tasmania, because whenever we do these projects, we don't have a lot of money, it's free. So everything related to Safewards is available on 2 sites. It's available on the UK site. Just do a Google on Safewards UK, it'll come up. There's also free information that anyone can download on the Victorian site as well. So it has been shown internationally to reduce instances of violence and aggression in the workplace. Okay, so the evidence and the research. Len Bowers and his colleagues did a massive, massive study. It was quite an extensive study, one of the largest that's ever been done, certainly in the realm of nursing, in relation to instances of violence and aggression. They looked at a lot of things. So when they talked about things like conflict, they looked at absolutely pretty much everything. Everything that could really be couched as conflict. So it was everything from, you know, not complying with the rules on a unit, to absconding, to not taking medication, to instances of self-harm, instances of aggression, and so forth. They also looked at multiple studies that have been done relating how you manage these sorts of instances. They conducted some of the largest studies ever, and in fact they looked at a total of 136 units right across the UK, and some units they studied for up to 4 years. So it was a really extensive study. Along the way, they looked at checklists, they interviewed staff, they interviewed consumers, carers, they came up with many ways of really eliciting information about what did work, what didn't work, and what was involved in these instances. Out of that, they actually came up with what was eventually 10 interventions. Initially, they came up with 300. So they tossed around all these ideas, had 300 interventions, distilled it down to, okay, these are the 10 that when we look at them, we think might actually have an impact on decreasing down instances of violence and aggression. The model itself was then subject to a randomised controlled study. And interestingly enough, when they actually took this model and then trialled it and did some research around it, it actually showed that they could decrease down instances of conflict by about 14.6%. Now that's a lot, And also decrease down containment by about 23.6%. And this is, again, we're working in the nursing environment. So really, really significant. So what it showed, basically, was that this was quite a robust model, but that it had applications in a lot of areas. This is what the model looks like. It looks really, really quite technical. Don't be put off by it. It's actually quite straightforward. So the domains on the outside of the model, such as patient community, patient characteristics, regulatory framework, physical environment, so on and so forth, are all of those factors, most of which are fixed, that we can't really influence. If we look at things like regulatory framework, we can't avoid working with the Mental Health Act when we're working in a psychiatric facility. If we're looking at patient characteristics, there are demographics. We know that young males, if we look at the research, slightly higher incidence of violence when we're dealing with young males in an inpatient environment. So all of those things, though, the Safewards model tells us, or shows us through the research, that we can actually intervene with some of these. There are things that staff can do. There are some things also that our consumers can do. However, all of these outside domains can actually lead to instances of conflict, and instances of conflict can end up in what the model terms as flashpoints. So that's when things are starting to get a little bit tricky, when we start to have raised voices, when we start to have instances where we've got something happening between staff and consumers that we know is going to escalate, that can escalate to violence, that can escalate to instances in a psychiatric inpatient setting, often of containment. So we do seclude people, unfortunately. We do restrain people in some of these instances. So this model is really about looking at how can we reduce that down. We know that whenever we have to go to those extreme interventions, sometimes we have to, but if we can reduce those down, we can also reduce down the instances where we're putting staff at risk, where we're putting consumers at risk, because that really is the point at which staff get injured, consumers get injured. It's traumatic for staff, it's also traumatic for consumers. And we know that it has a knock-on effect. You were talking earlier about resilience. We know that over periods of time, being repeatedly exposed to these instances, whether that be consumer or staff member, has an impact on us. So the concept of the Safewards model is that, yes, we start with these outside domains. It can escalate and end up with containment, but we can intervene. So if we look at some of the flashpoint examples, so I'll whiz through these because I'm very aware that we're going to run out of time. But if we look at, say, the staff team or the internal structure domain, we are often setting limits around our consumers. You'll notice on here it uses patients. That's because, being a UK model, a lot of the terminology is just slightly different to what would be our everyday use here. So when we're dealing with consumers, we're setting limits. That can be a flashpoint, telling information or news that's upsetting another. Inconsistencies in staff. We know that when teams are inconsistent in an inpatient setting, a psychiatric setting, it can lead to instances of conflict. It's very evident in the environment that I work in the secure environment. We have a lot of constraints, and the lack of consistency is probably our number one flashpoint. The physical environment, when we're looking at that, it's interesting what came out of Safewards was that when I talked to a lot of consumers and also talked to some staff, they found that paying attention to our environment can really actually make a difference to instances of conflict arising. Consumers come into our environment, if they look at it and there are holes in the walls, things aren't repaired, taken care of, it causes frustration, but it also makes them think, well, if you can't look after the environment, then how the hell are you going to look after me? So simple things like paying attention to repair of equipment, paying attention to what the physical environment looks like can actually decrease down those instances of violence. The outside hospital domains, things that we often don't have control over, but having an understanding about the context and the environment in which our consumers come from. So what's going on outside for them that can actually impact on how they react and respond and are with us in the inpatient environment. Patient community, we know that when we bring people together who may not choose to be together, we have consumers on the unit, some behaviours can actually be almost contagious. Something will start with one and it will lead on to another, and people can actually feed off each other. It happens with staff, it also happens with our consumers. So things about the environment, it's like what can we change about the environment to stop those sorts of things happening? The patient characteristics, we're often asking them to stop doing something, asking them to do something. We're forever firing, instructions and so forth. Depending on that individual's personality construct, depending on whether they're psychotic, whether they're experiencing other things, can lead to a flashpoint. The regulatory framework, as I said before, whether we're constrained or the consumer's constrained by the Mental Health Act, the Criminal Justice Mental Impairment Act, the Corrections Act, whatever that might be, it places those constraints and can lead to a flashpoint. So conflict and containment. So what does Safewards call conflict? It's a really broad terminology that they use. It really is anything that threatens staff, patients, or carers within a certain environment. So it can be anything from verbal abuse to self-harm to actual violence. It's on the whole continuum. Containment, I think often when we think about containment as health workers, we think about seclusion and restraint. We think about the really extreme end of containment, but consumers think a little bit differently often about containment than we do. They think about things like when we give them PRN medication, that's a form of containment. When we put someone from hourly obs, for instance, on an inpatient unit to 15-minute obs, that's a form of containment. The locked door, having to actually ask, even if you know you can go out, but if you have to actually ask to go out and have to wait, that's a form of containment. So we use containment all the time, but we don't often think about that in that context. What we do know from the studies with Safewards is that staff can influence conflict and containment along the whole spectrum. We can influence it from when everything starts to happen in the beginning by the way in which we interact. We can also influence even after the events occurred about how we manage the after event. This is just looking at a linear model, if you like, just saying that, look, all along that way, we can do something. So, the 10 interventions that they came up with, really simple, really straightforward, make a lot of sense to nurses. First one's clear mutual expectations, and I'll talk about each of them a little bit. Second one is soft words. Third one, know each other. Fourth one, positive words. 5, bad news mitigation. 6, talk down. 7 is a mutual help meeting, 8 is calm down methods, and 9 is reassurance, 10 is discharge messages. This model being designed for UK, Victoria Health took a look at it. They started looking at it probably in 2015 and thought, well look, the evidence is there, it can reduce down incidents of conflict, but is it applicable to an Australian environment? So they did a study, they implemented it on 6 or 7 units for a 3-month trial period in Victoria. They didn't find an awful lot of difference. They were particularly looking at seclusion and restraint events. They didn't notice too much. They continued on with the study, continued to evaluate it. What they found was over the 12-month time frame that once it was actually embedded into practice, these simple interventions actually decreased down instances of conflict, decreased down instances of containment. They improved some consumer engagement. They found that consumers thought that the values of Safewards sat quite aligned with their own values. Staff reported less conflict on the units where they were using the Safewards interventions. And so now Victoria are actually implementing it right across all of their inpatient areas. So they just have another 2 years funding, so they're rolling this out into every inpatient unit. When they actually did an evaluation, which was done by the University of Melbourne, they found that there were particular interventions that made a lot of sense to consumers particularly, and those are the 3 that are highlighted there. So the mutual help meetings, calm down methods and the discharge messages were the ones that consumers particularly found most useful. This is what the community of practice looks like on the Facebook page. It's just a fantastic tool if you are working in an inpatient psychiatric facility. because you can just make contact with colleagues from all over the world. You can talk about the issues that you're having and talk with them about what they might be doing to resolve them. If you go onto any of the Safewards site, whether you go into the actual UK website or you go into the Facebook page, this will come up where you can actually go in and look at any of the interventions. So in each of these, they've got descriptions of each intervention, how you implement it, plans around how to implement it, how to evaluate it, and it's really straightforward. They also have in there examples of the model, from a very simple explanation of the model, which you can give consumers, right through to a more advanced sort of look at the model. So if we look at each of them, they're really quite straightforward. So clear mutual expectations. This is really straightforward. We know that conflict occurs on inpatient units, but I think also anywhere between consumers and healthcare workers, when we don't have a clear understanding of what our mutual expectations of each other are. This is what this intervention is about. It's really straightforward. It's actually just setting down what we expect from each other. Often in inpatient psych settings, we're always about telling consumers what we expect them to do. We don't want you to do this, we want you to do that, you must comply with this, la-di-ra-di-ra. It goes on and on and on. But what we don't often do is put it out there as being a mutual expectation. So this is a slight shift or difference in doing that in the Safewards model, is that what I ask you to do as a consumer, then you can expect me to do as a staff member. So it's really about getting together with consumers, naming up what your expectations are, what you expect from someone during that inpatient stay, both staff and consumer. Putting it out there. Safewards, a lot of them, laminate it, stick it up on the wall, give it to people on admission. It's all very clear. It kind of sets the tone for what we expect. And it can be really quite simple. You know, a lot of it is just as simple as, this is an example of one that's been used in the UK. So it's just things like, you know, that as staff, we will try and accommodate your requests. It sounds perfectly reasonable. But in reality, this isn't always what happens in inpatient settings. I think sometimes we talk about these things, but we don't always do them. So Safewards is about trying to keep us on the straight and narrow, is actually trying to hold us as clinicians accountable for what we do, the way we do it, and how we put it across. Soft words is really straightforward. It's about basic humanity. It's about being respectful. It's about just treating every individual with common decency. It's not rocket science. So it's thinking about, when we are talking to someone, how are we appearing? What's our body language doing? What are we saying? How are we getting the message across? So it's just really quite straightforward. Know each other. This one was quite controversial in the UK because it's actually about us giving some information to our consumers. This is putting together something quite straightforward on every unit. It is the starting point for conversation between consumers and staff, and it's just simple things. Things like, you know, who's your favourite football team? You know, what sort of music do you like? What kind of books do you read? It's not breaching confidentiality. We ask the most invasive questions often of our consumers. We want to know about their sex life when they come in mental health areas. We want to know the most intimate details. We ask them about self-harm behaviours, all sorts of things, but we don't actually ever talk about ourselves. This is just trying to level the playing field a little bit. It gives a starting point. That's an example of one, but I think we're getting out of time, so we're going to keep going. So positive words. Positive words is really about reframing. It's particularly designed for handover. In handover, we tend to catastrophise. We tend to talk about all the negative things. We talk about all of the behaviours that are difficult to manage. This is actually trying to reframe that a little bit. Yes, we do need to talk about risk issues. We do need to pass on information. But let's actually think about what the strengths are for a particular consumer and make a concerted effort with everybody that we hand over, at any kind of handover from shift to shift, that we talk about something positive about them, and we talk about their strengths. Bad news mitigation. Everybody gets bad news. we're very good at giving bad news. We're not often very good at wrapping supports around that. So thinking about who's the best person to deliver it. What's the team going to provide in the way of supports when we're giving out that bad news? What's worked before for that consumer? What will that consumer need? So it's actually anticipating things. Talk down, this is about de-escalation. I won't go into that. Most staff working in mental health services are certainly here in Tasmania all would cover that.